Okay, so the purpose of this video is that we're going to talk about internal potassium balance and also external potassium balance in terms of how the kidney actually handles potassium. So to sort of build on the end of that last video, when we were talking about shifting potassium into cells and why it's important, now let's talk about how to actually do that. So I've already listed here the main things that move potassium into cells. And these are very clinically relevant. So insulin and also beta 2 agonists. So this includes catecholamines like epinephrine, but also albuterol. Um, these will stimulate the sodium potassium ATPase and will increase potassium movement into cells. And it's very effective. Also, remember alkalemia can move potassium into cells. So remember intracellular buffering occurs whenever there's a change in the pH. So if pH goes up, the hydrogen ions inside the cells will actually move out, but in exchange, in order to keep things electrically neutral, potassium has to move into cells. So some shifting will occur with alkalemia. Also, like really severe hypothermia has been shown to cause pretty profound potassium shifting into cells. Okay, so as you can see, I've added a list of things that cause potassium to shift outside of cells. And you could probably come up with some of this list yourself. Just think of the opposite of the things that cause potassium to shift in. So if insulin moves it in, well, lack of insulin will cause potassium to shift out. So think about patient you're seeing with DKA. They tend to be mildly hyperkalemic, but it's just because potassium has shifted. Likewise, beta antagonists, so actually beta blockers. Some beta blockers can cause mild hyperkalemia. On the other spectrum for acid-base disorder, so acidemia, so if the pH is low, buffering will occur such that hydrogen ion will move into cells, and in exchange, potassium has to leave the cell. And remember, that's just for buffering to try and reduce the magnitude of the change in pH. Also, high plasma tonicity. So if the extracellular environment is hypertonic, let's say even in the setting of hyperglycemia with a lot of glucose here, water will move from inside the cell to outside the cell. And there's something called solvent drag, so that pulls potassium with it. That can be another mechanism that can bring potassium from inside to outside the cells. And also, I know this isn't technically potassium shifting, but cell lysis could also be a source of potassium. So if cells are being destroyed, whether it's through ischemia or tumor lysis syndrome, that can cause potassium to move from its prior intracellular environment into the extracellular environment. Something to always think about when you're working up a patient with hyperkalemia. Okay, so now we're moving on to renal potassium handling, or sort of external balance of potassium. And what we're looking at here is the nephron, as you may recognize. And so in the proximal tubule, about 67% of potassium is reabsorbed. Likewise, in the thick ascending limb, about 25% is reabsorbed. And really, most of this is unregulated reabsorption, which means just reabsorption that's going to take place no matter what the situation. Because remember the initial picture I showed in the last video, we only need to excrete a small amount of potassium under normal conditions. The rest of it we want to hold on to. And the majority of the GFR, the filtrate that contains potassium, is potassium we're going to want to reclaim. What is important to note is that in the collecting ducts, potassium absorption and excretion is tightly regulated. And this is where the kidney fine-tunes potassium excretion. And that's where we're going to go into right now. So I'll show you how we do it. Okay, so here we are in the collecting duct. We're looking at two different cell types. One is the principal cell, And this cell is primarily involved in potassium excretion. So we're going to go through all the mechanisms that could drive potassium excretion. The cell down here is the alpha intercalated cell. You may remember this from the acid-base lectures. It's involved in hydrogen ion excretion, but as an aside, it can also reabsorb potassium in exchange for hydrogen ion secretion. So, in the setting of hypokalemia or low total body potassium, this would be active reabsorbing potassium. But let's focus more on the principal cell and ways we're able to get rid of potassium. Okay, so here I've added 2 luminal factors that will increase potassium secretion. So remember, this is the urinary lumen here, and this is the interstitial or blood side over here. So one of these is increased sodium delivery to the principal cell. So the way this works is that there's a channel called ENaC, epithelial sodium channel. Sodium, as it's presented in the urine, it will move across this channel. It's very selective to sodium. As it is taken into the cell, it actually will make the cell positive with respect to the urine. So the urine will actually be negative and have a negative potential. What this does, it will help the driving force for potassium to leave the cell. So remember, the cell has high levels of potassium intracellularly, and so if there's a negative extracellular environment, potassium is going to want to leave the cell. And so the more sodium shown to this channel, it's going to reabsorb it. As a result, the more negative this lumen is, the more potassium will be secreted. And this channel is called ROMK. So it's a channel that sits on the principal cell, and these two guys always sit side by side. And it's the principal channel for which potassium is going to leave the cell here. So the other factor is increased urine flow. So in addition to high urine flow likely delivering more sodium, independent of sodium, high urine flow will increase potassium secretion. And see, this thing right here is called the primary cilium. So most cells have them, and renal tubular cells have them. Whenever this cilia is moved by urine flow, so I'm just going to draw the motion here. So urine's flowing by and it's moving the cilium. This will actually stimulate ROMK, and it will help it remain open and let potassium leave the cell that way. So overall, the more sodium that's delivered to this distal portion of the cell, and also the more urine that passes by, both of these things will lead to potassium secretion. So in some situations, we're able to treat hyperkalemia with just giving someone normal saline. If we make them pee more, they'll lose more. And this is also how diuretics lead to hypokalemia. More sodium is making it distally, and the urine flow increases. Okay, so now I've added some so-called environmental factors that will aid in potassium secretion in the kidney. One, high dietary potassium. So if you're going to eat more potassium-containing foods, think about it, your serum potassium would transiently rise. As serum potassium rises, you have more potassium to pack into the cell. And one thing is just that if the diffusion gradient is high, such that there's higher levels of potassium inside the cell, more can travel down the ROMK channel into the urine. Remember, this is different than the cardiac myocyte I showed you earlier, where the extracellular potassium was 5 and the intracellular was 150. Here, as long as urine is flowing by here, urine potassium is quite low. So as long as the principal cell is packed with potassium, there will be a diffusion gradient to favor potassium excretion. High dietary potassium will just accentuate that. Likewise, a change in pH that puts more potassium inside the cell, that will promote potassium secretion. So remember, in the setting of alkalosis, so a high pH, hydrogen ion will leave the cell and potassium will enter the cell. And so if the principal cell gets packed with potassium, really just due to buffering, due to the pH, more potassium is able to be excreted via ROMK. The converse is true. If the pH is low, then less potassium would be available inside the cell. And this is just due to the buffering effects we saw previously. The next environmental factor is really important, and this is aldosterone. So this is a hormone that's secreted by the adrenal gland, and it has two primary stimulators. One, high serum potassium, so that stimulates production of aldosterone, and also the RAS system, so renin-angiotensin. So angiotensin 2 stimulates aldosterone production. These two stimuli will produce aldosterone. Aldosterone travels to the principal cell. It binds an intracellular receptor called the mineralocorticoid receptor, which is actually a transcription factor. So that travels to the DNA, and it produces its gene products, which are basically, one, to increase the sodium-potassium ATPase, right? So that will pack more potassium into the cell, and it will also increase the number and activity of this ENaC channel. So it's allowing the cell to bring more sodium into the cell, which, if you think about it, would fuel the sodium-potassium ATPase, pack more potassium into the cell, and if there's more potassium in the cell, there's more to go down this channel. If ENaC is more active, the lumen is more negative, so more potassium can travel down this channel. So this is how aldosterone works in potassium secretion. And this is a key pathway for staying in potassium balance. Think about it, patients who are on blockers of the aldosterone pathway, so spironolactone and eplerenone, patients tend to have a slight increase in the serum potassium. And this is why, because this is so key. So I know this is kind of quick, but I hope it's a pretty good overall picture on how the kidney handles potassium excretion. These are the five, primary things that drive potassium secretion. These are very clinically important. The luminal factors, dietary potassium is certainly important, and aldosterone is very important. The change in pH certainly causes some shifting that can contribute. I think the others are definitely clinically relevant and worth memorizing and understanding now.